introduce Professor Figaji is the head of pediatric neurosurgery at the Red Cross War Memorial Hospital in Cape Town, and he will be talking about intramedullary spinal cord tumors in children. Quite an interesting topic. So, Professor, please start.
Great, thank you. I will just set up my my presentation. All right. Hope you can all see me.
Yes, we can.
You can see excellent. Well, great. Thanks. Let's get started then. So thank you very much for the invitation. Thank you for all of those of you who have logged in. And I'm going to be speaking about intramedullary spinal cord tumors in children. Much of what you, if you are residents or registrars, much of what you need to know about intramedullary spinal cord tumors you can get from standard textbook chapters. What I'm going to try to do over the next 20 minutes or so is to talk about some of the aspects of the surgical management, and in particular the way that I like to treat patients with spinal cord tumors. And everyone has a slightly different way of managing patients surgically. And the way that we all develop our technique is the things that we get taught by our mentors. And my mentors are Jonathan Peter and Graham Figaji in Cape Town. And then other people that we come into contact with over the years, colleagues, senior colleagues. And in particular for spinal cord tumors, I learned a huge amount from Rick Abbott from the New York area and from Francesco Sala. So I'd start with just a very brief historical background, an overview of spinal cord tumors over the last century or so, since the first description by Ellsberg. And it was an interesting description because they talk about how they opened up the dura and they performed a myelotomy to remove the tumor, but the patient became hemodynamically unstable, so they had to close up before they could remove the tumor. And the patient stabilized, they came back a couple of weeks later, and the tumor had largely delivered itself. And that was the first description of the technique that maybe some of your kind of older surgical mentors have told you about, myelotomies and tumors delivering themselves. Unfortunately, the very next patient that they did, where they tried the same maneuver, didn't work that well. But since that first description, we went through a long period of conservatism about spinal cord tumors, largely because the morbidity was thought to be so high, especially for high-lying and ventrally located tumors, and in particular the ones that weren't very well encapsulated. And then in the 1980s and the 1990s, from our point of view, the one person that did the single greatest effort, or the group of people really, was the group in New York led by Fred Epstein as the surgeon there, and with a wonderful collaboration with a neurophysiologist by the name of Vedran Delitas. And they, by trial and error, developed surgical techniques and strategies based on intraoperative neurophysiology to make surgery for tumors in the brainstem and in the spinal cord safer than it was in the past. And they had many fellows over the years. Francesco Sala was one of them, and I think this is one of the most important papers in spinal cord tumors. And essentially, Francesco Sala learned his techniques from Vedran Delitas and then took it back to Verona, where his mentor, in fact, had a large series of tumors that he'd already operated on, and found that it had a strong impact on the way that they managed patients. And key to that was the monitoring of not only motorboat potentials, but something called the D-wave electrode. We'll show you that a little bit later. It's a little electrode placed in the epidural space where you elicit something called a D-wave. That's a very robust wave and has a strong correlation with motor outcome. So even in situations where you've lost motorboat potentials and you've retained the D wave above 50% of its amplitude, those patients will often have a transient deficit that recovers. But if you lose the D wave or it drops below its 50% amplitude, the chances are then that the patient's going to have a permanent deficit. So we typically would monitor somatosensory potentials, motorboat potentials in the legs or the arms, depending on how high or low it is, and then the D wave as well. So very broadly, and these are some of the principles that we're going to talk about over the next few slides. Critical thing is preoperative assessment, so good clinical history and clinical exam, and radiological assessment. Where is the tumor? Where is it located? Does it look like it's reasonably well demarcated? Does it enhance very well? And well, what is the likely morbidity associated with removing it? IM preparation is very important. One of the things I learned from Francesco was that bad neurophysiology can be worse than no neurophysiology at all. So if you're going to be doing intraoperative neurophysiological monitoring, it has to be done by somebody who knows what he or she is doing. And preferably the surgeon needs to have a good understanding of the IOM techniques also being used. Localization of the tumor, I like to put a little marker on where I think the top spinous process is, and then x-ray the patient on the morning just before surgery, and use that as a marker of the rostral extent of the tumor. The laminotomy will show you is a very quick technique using a high-speed drill. How you open the dura, I like to tent the dura to keep it open. How you find the midline, how you enter the cord, how you go about dissecting the tumor, and very importantly, how do you go through the process of decision-making about when to stop or when to press on. How we close the dura and how we put the bone back in children. So we'll go through all of those things. So this very briefly is our setup. This is when we started IAM many years ago. So essentially the neurophysiologist sits by a laptop, and his screen is shared with us so we can see what's happening in real time. First, the laminotomy or the laminar Plasti. This is what it looks like. This I learned from Rick Abbott. You can do a 10-level laminotomy in children literally within a couple of minutes. Very, very easy to do. You need to do it a few times to get comfortable with it. The mistakes that I've seen people make is to try to go too laterally, and then they get stuck in the joint, or they pull up too hard in fear of pushing down on the spinal cord and the spinal cord tumor. They come up to pull up too hard, and you can't get into the proper space. And then you can either trapdoor the laminotomy back, or you can, which I usually do, just take it off completely. And then in young children, I don't put any plates on. I use a non-absorbable suture and create a sling. It's important to create a sling so that when you close the wound, and with movement, with back movement, there's no ventral movement of that spinal segment, because theoretically, of course, that could compress the spinal cord. So we create a sling, and that's generally very stable. This is what it looks like at the end. And kids are wonderful. You'll come back in a month's time, as sometimes one has to do if you can't take out the tumor at the outset because of IOM changes. That will be healed completely. You'd have to redo the laminotomy, in fact. The spinal cord surface, the question is always what veins, what vessels can you take, and how do you find the correct entry? Can be difficult. There's a huge variety in the vascular appearance of the posterior cord. It's always impossible. It's never possible to avoid sacrificing veins completely. The general principles are you want to limit it, and when you do take veins, always do that with bipolar under wash. There's quite a variety of what the spinal cord looks like. Sometimes the tumor is evident on the surface, more often it isn't. The cord's very swollen, you can't see the midline. One of the things I was taught was that you can crank up the magnification of the microscope and look for the midline, which is the point at which there are small vessels that bilaterally dive into the midline. It's not very easy to determine. I can determine it as in few cases, literally. So well, what I usually do is have a very careful look at where the dorsal root entry zones are and where the bulge of the tumor is, and try to go into the midline between the dorsal root entry zones, or if there's a clear area where the tumor is presenting itself, and try to minimize the vessels that you sacrifice. Rostral and caudal cysts are very common in children. And those are very, very useful as a marker of how high to go and how low to go. Once you get into the rostral caudal cyst, it's a wonderful anatomical landmark. So I want to show you a few illustrative cases, and each of these cases will demonstrate something different about the surgical technique. The first is an 11-year-old girl. She presented very well, but just with neck pain, with some sensory symptoms in her right arm, a little bit of right shoulder weakness, and a slight change in her voice. And this was a tumor, so she's got a very brightly enhancing tumor. It looks like a JPA, the ventral aspect of the cord. And the problem here, of course, it's quite high up. So it's at C2, C3. It has a rostral cyst that goes well up into the brainstem. So she's got syringobulbar. So we had an interesting discussion about it in our department, and that was, what is the kind of mobility that you would accept or anticipate with an operation like this in the era of IOM. Of course, you know that the surgery is the only solution here. It's a benign tumor, and radiotherapy is not really going to work with that with the big syringobulbar, and she's likely going to develop respiratory compromise or low cranial nerve palsies, and that's exactly what she did. So a few days after she presented, she was scheduled for surgery. She suddenly developed a respiratory arrest. So we had to operate on an emergently. We first drained the rostral syrinx to relieve the respiratory embarrassment. This is the D-wave electrode. We always put it in caudally. I'll show you that again a little bit later. This is opening the back of the cord. I'll show it to you all in detail. We use something called an iris knife for sharp dissection. Once you enter the tumor, it's usually quite soft. Sometimes it's quite fibrous, and you need to use that iris knife again. And then slowly you go through the process of taking out the tumor, and we'll go through all these steps again. But this is just to demonstrate what happens with benign tumors in children, is that you can take the whole tumor out, and here we were just left with the ventral pier, as you can see here in the T1 axial. The motor columns are completely split. And you look at the scan, and it looks terrible. The tumor's out, but it looks horrific in terms of what's left by the cord. But the patient, this is the key thing, is completely functional. So this was her about 2 weeks post-surgery, intact sensation, normal proprioception, position sense, and neurologically intact. So this is now several years down the line. It's a JPA. She's completely cured. So that's the one lesson about spinal cord tumors in children. They're usually benign, and so surgery can cure them. This is a 5-year-old girl. She presented only with mild scoliosis and no neurological deficit that could be clinically detected. And this is often a situation that we're faced with. A really challenging looking tumor. It's T1 with contrast. You can see it extends over several segments. Large rostral and caudal cyst. When you look on the axial, it's very common not to be able to see any clear demarcation between the spinal cord and the spinal cord tumor. It's always a challenge when these patients are so neurologically intact. But of course, this is the best time to operate on them. And of course, the greater your neurological deficit is before operation, the higher your chance of developing a further neurological deterioration, presumably because the cord is already under some stretch and ischemic damage. So this is what it looks like. And this is how we open the dura. Fortunately, this tumor presented somewhat on the posterior surface. This was a mixed papillary astrocytoma, and sucks very well. KUSA is very useful in these circumstances. I'll talk a little bit more about KUSA a bit later on. And this is what the cord looks like afterwards. It doesn't look good. It's very thinned out. And without intraoperative neurophysiology, one would be incredibly anxious about what this patient's going to be doing postoperatively. So you have anxiety, the patient has to be woken up from anesthesia, and then filled with anxiety, you want to see what the legs are doing. One of the comforting things about intraoperative neurophysiology, and I think this is a really important point, that people often think of intraoperative neurophysiology as a handbrake, as a tool to tell you when to stop. But there's a flip side to that, and it's also a tool to tell you when to go on. So if you've got full motorboat potentials and you have an intact D wave, then you have a huge amount of confidence in pressing the resection margins of the tumor, knowing that the patient is going to wake up either with no deficit or with a temporary deficit. And this was a scan, a postoperative scan. The tumor's out, sagittal and axial, and this was her about a month later. Still got a bit of scoliosis, and that needed to be corrected. But again, several years down the line, it's a benign tumor, there's been no recurrence. Next case, a slightly different illustration, a 13-year-old boy who presented with long-standing scoliosis. And the interesting thing is when you speak to the parents, they first took it to a practitioner when he was just a year old, and they'd noticed a slight abnormality of the curve of his spine. And they were reassured. They said they were told there was nothing wrong. And over time, he developed progressive scoliosis that they sat on until he developed a little bit of leg weakness. This was his scan. One of the challenges in scanning patients with scoliosis is to get good sagittal and axial images. Doesn't project very well here, unfortunately, but he's got an enlarged cervicothoracic tumor with a rostral and caudal cyst. So this is what it looked like at surgery. Slightly different to many of the other tumors in that there was a thick yellow gliotic plane, presumably because the tumor had literally been there for 12, 13 years. And the distinction between normal tissue, tumor, and gliotic plane was difficult to make. Unfortunately, it went well. His intraoperative neurophysiology was stable, and again, it was a benign JPA. This was him about a month later. Another case, just in fact, a week and a half ago, a child was sent down to us from another center, a 12-year-old boy with 1 month history of back pain, sensory and motor symptoms in the legs, and some leg weakness. This was his tumor, a mid-thoracic tumor, again, syrinx both rostrally and caudally, and then Hans's looks like a JPA. And so what I tend to do is use a dissector to create a little bit of epidural space. This is the D-wave electrode. It has 3 contact points that are reference points for creating the D-wave. Use sharp dissection to open up the dura, and then we tear the dura along its longitudinal fibers, both rostrally and caudally. And then I like to tent the dura back. Some people like to put sutures on and hang them over with an artery clip. I prefer to tent them. It gives you very good lateral retraction. Couldn't appreciate the midline, so we had to make a decision between the dorsal root entry zones. I use an iris knife or an arachnoid knife to open up the pier. Sometimes I like to leave bridging veins, and it's not always possible to maintain them. I like to open up the cord like this, just with the bipolar forceps. Always remember to take biopsy specimens and biobank them if you can. As I said earlier, sometimes the tumor is quite fibrous, so even when you're in the middle of the tumor, you still need to use some sharp dissection. And then the Kusa is an incredibly useful instrument. You have to be careful with it, so it's on low ultrasonic capacity, low suction, and it depends on where you are. So here's the caudal cyst. So when you get to the caudal cyst and the rostral cyst, you know you're very close to normal parenchyma, and then you want to really slow down, perhaps put the Kuza down and use normal suction. Because those are the areas where you can do a huge amount of damage. Sometimes you have lots of vessels that have to be coagulated. I like to try to pick up the vessels off the tumor and coagulate them. You've got to be very cautious about the heat that you can generate into the cord. And then always getting a sense of where you are in terms of how much tumor you've resected, how far you are from the lateral aspect. It can look incredibly thin, but with normal function. And then the ventral columns, one just has to have a huge amount of experience, because with astrocytomas in particular, there's very rarely a very good plane. So you have to have a feel for what normal cord looks like and what astrocytoma looks like. And again, if the intraoperative neurophysiology is stable, you just keep on going slowly but surely. And then not everybody does this, but I like to close the spinal cord. I like to close the cavity. I use an 8-O-proline. And then I also like to put on a dural patch, which I use 5-O-proline. I put in some gel foam. This is Bicol. And then in older kids, I'll put a plating system on. And so this was his scan immediately post-op. There's a bit of blood. I think there may be a little bit of tumor left there, but it's less than 5%, and it's a JPA. So I think that should be fine. And then one last case, just to illustrate something slightly different. So a challenging case, a child with a ganglioglioma. They tend to occur in younger children. And he presented just with very non-specific signs of arching his back, looked like he was in pain, irritable, a very indiscreet tumor with patchy enhancement from upper cervical down to upper thoracic. And the unusual thing about this kid, which you see sometimes, is that the spinal cord is completely rotated and you can't get into the midline myelotomy posteriorly. And so sometimes what I do is go lateral to the dorsal root entry zone, and you use what one would call kind of skip entries, skip myelotomies into the spinal cord in between the dorsal roots while protecting those roots. This is just an illustration of the motorboat potentials. This is on the left, this is on the right. There's a baseline and a current. And this was one of those patients who lost his motorboat potential. So this is the current. You can see on the left side, the right side was preserved. This is the APB. So this is the arm. So those are your controls. So you know it's not a technical problem. Left and right arms okay. Right legs okay. A little bit softer here in the right tib. But we've lost left tib, left quad, left AH. Abducus hallucis. So what you do in this circumstance, you stop what you're doing. You get the anesthetist. You get the anesthetist to raise the blood pressure. You irrigate and you wait. And essentially, either these signals are going to come back, so you know that there's some tolerance to the cord, and you can continue, or they don't come back, and then you need to make a decision about whether you're going to press on or you're going to hold off. One of the things I learned from Rick Abbott is that if you've run into serious neurophysiological changes that don't recover with all the conservative measures, getting the temperature up, blood pressure, irrigation, etc., then stop what you're doing. And there's no shame in coming back sometimes in a month. And if the patient doesn't have a deficit, and then often that neurophysiology reestablishes itself because the patient has recovered, and then you can often go in and go on and take out the rest of the tumor. And then just very lastly, for tumors that extend up rostrally into the brainstem, or if they've got syrinxes, we also do brainstem monitoring. So this is one of the ways you can monitor the vocal cord. So that's wrapped around the endotracheal tube. And then we put in little hook wire electrodes in the soft palate bilaterally, 2 on either side for glossopharyngeal. And then we also put in those same hook wire electrodes into the tongue, so you can monitor hypoglossal. So those are quite useful for cervicomedullary tumors. Not easy to do, and impedance often is a problem, but incredibly useful when you get stable signals. So in summary, in children, most tumors are benign and they can be cured. They're usually astrocytomas. Often there isn't a clear plane, but the tumor nevertheless can be carefully resected. And a key aspect of this, as I said, is having a sense, and unfortunately that has to come with experience, of what is normal, what's normal chord, what's the glytic plane, and what's tumor. For us, and I think many centers all over the world, intraoperative neurophysiology is key in making decisions. And I think this is one of the best indications for the use of intraoperative neurophysiology. Very important to understand that it's more than just a handbrake, because if those signals are robust, you have a huge amount of confidence in being more aggressive about your surgery, not less aggressive. It depends really on good neurophysiology, but not only a good neurophysiologist, but a surgeon that has an understanding of intraoperative neurophysiology as well. And then, as I demonstrated with the last case, if you run into trouble, there's no harm in coming back. The neurophysiology is unstable, and it happens in maybe 20–25% of the cases. And of those cases, some of those reestablish themselves very quickly. Sometimes it doesn't. If it doesn't, then you close up, you come back in a month or so if the patient's clinically well. And then very lastly, for those of you who are interested in pediatric neurosurgery, either you want to be pediatric neurosurgeons, or there's a large part of your practice that is pediatric neurosurgery. If you've never been to one of the ISBN meetings, the International Society for Pediatric Neurosurgery, it's a really great international group to be connected with. If you are interested in becoming a member, you don't have to be a full-time pediatric neurosurgeon. You just have to have some of your practice dedicated to children. I'm the membership secretary at the moment, so please contact me. This is my details below. I'm sure you can get in contact with me also through the WFNS. So thank you. That brings my presentation to a close. If you have any questions, I'd be happy to take it now.
Thank you very much. This was a really fantastic presentation. I might start off with a question. When you start the tumor resection and you take a biopsy, and if the tumor biopsy results is ependymoma or astrocytoma, how much does that alter your decision during the case?
It doesn't at all. So I always, the goal is always to take out the tumor. I mentioned the importance of taking a biopsy because early on, because once you start resecting, it's quite easy to forget. But the provisional histology never, to my knowledge, I don't think in any of my cases has led me to a different strategy. The strategy is always to try to take it out. Of course, if it's a highly malignant tumor that sometimes you get in adults, maybe a little bit different. But in children, the vast majority of them are benign. And ependymoma is actually not that common in children. Most of the time, they're astrocytomas, pylomyxoids, or gangliogliomas. But the goal for all of them is to try to take them out. What helps with ependymomas is that they tend to be a little bit better demarcated than the astrocytomas, so they're a little bit easier to do. But for all of them, the goal is to try to take it out.
Okay.
One of the things I also learned from Rick is that, so our goal is always to do a complete resection, but you know, even if you can just get, especially if you don't have intraoperative neurophysiology, even if you can just get an 80 or 90% resection in a benign tumor, that's often good enough.
And when do you do a duroplasty? Is that a routine in all cases or some cases?
I generally do, unless I find that the dura is incredibly patulous. I like to do it because it's similar to the principles I learned from Dackling Pang with tethered cord surgery. The goal is to try to get a nice capacious dural sac that's filled with CSF. And theoretically, I don't know if practically if it's real, but theoretically at least, to try to limit any adhesions dorsally.
Okay.
Okay. So,
So
if anyone have any question, he can type it directly or raise hand to talk. I think Elam, he or she have a question. You can speak, Elam. Still with us, Elam? If I'm pronouncing the name correctly. Anyone have any question?
Hello, can you hear me?
Yes, we can. Go ahead.
Yeah, this is Elam. I'm a young neurosurgeon from Malawi. I'm an Ethiopian neurosurgeon. I came here for working for a few months. So I went back when I was a resident. We had faced lots of cases, especially of intramedullary spinal cord tumors in children. And the problem we face is because we don't have this neurophysiology monitorings. Patients usually end up with having a neurologic deficit, which is significant postoperatively. Actually, you have mentioned some of them that at least trying to debulk 80 to 90% would be enough. But is there a place for like trying to resect the whole tumor, or if it's well demarcated, or should we just continue on debulking if we don't have the actual neurophysiologic monitorings?
Yeah, I think that is a tricky situation, but keep in mind that there are lots of places that don't have intraoperative neurophysiology. And it's not to say that if you don't have intraoperative neurophysiology, you can't do a good job. There are lots of people with a huge amount of experience without taking spinal cord tumors out without neurophysiology. I think there are a couple of principles. I think one is that one probably should be more conservative, because especially with benign tumors, and it's a conservatism that we see that has crept in over time also with other astrocytomas where in children where the surgery has high morbidity, like the hypothalamic and optic gliomas. So their long-term survival is excellent. It's over 90%. So the pendulum has swung in that situation towards chemotherapy and radiotherapy, and reserving surgery for the ones that don't respond or the ones that are particularly eccentric. The point is that you never want to harm a patient, especially with a benign tumor. So I think the key thing, if you don't have any measure of detecting whether you're causing a deficit, is to be relatively conservative, stay within the tumor, and then how aggressively you push it depends on whether there is a plane or not. So if you've got a pretty decent plane and you're fairly comfortable with that plane, you'll be a little bit more aggressive about trying to take the tumor out, because you can clearly distinguish between what is normal and what's abnormal. With a lot of these astrocytomas, of course, it's not easy to determine that plane. And in that context, I think the goal that I would recommend is a relatively conservative debulking of 80% of the tumor. Now, stay within the confines of the tumor, and try not to create a neurological deficit. I think that's the key thing, because even if you leave the patient with some tumor behind, either that tumor won't grow, or it will involute, or it can be treated with chemotherapy and radiotherapy. But if you leave the patient with a neurological deficit, of course, that's permanent, and there's no coming back from that.
Yeah. Thank you so much.
We have a question here from Dr. Fahad. He's saying, can we have more details about neurophysiology protocol for intramedullary tumors?
You want some more details?
Yeah, about the protocol you are using for intramedullary tumors.
So we use somatosensory potentials. Well, firstly, it depends on where the tumor is. So your approach to something in the conus versus the mid-thoracic, cervical, upper cervical area is going to be slightly different because you're worried about different neural pathways. But as a general principle, we use somatosensory potentials. So we use in the arms and the legs. If it's outside of the cervical cord, then the arms are really just a control for the somatosensory potentials in the legs, so that if you run into trouble, you can easily and quickly distinguish that trouble from a neurophysiological or anatomical cause versus troubleshooting, anesthetic, neurophysiological noise, etc., technical problem. Similar with motor potentials, we also have controls in the arms. And then we try to monitor at least 2 or 3 muscle groups, depending on where it is. Find the best muscle groups for us to target. For thoracic and cervical regions are tibialis anterior and abusus hallucis. So those are quite reliable muscle groups. But we'll often go more than 2 muscle groups. But if you are constrained, then I think those 2 muscle groups are pretty good. The somatosensories are posterior tibial. The controls in the hands are median for somatosensory potentials and APB for the hands, the motorboat potentials. So that's somatosensory potentials and motorboat potentials. And then the third thing is the D-wave electrode. So as I showed you, it's a little electrode with 3 contacts that you put in the epidural space just below the tumor. And of course, if it's a conus tumor, then it's useless. But you need some cord below the tumor. And if you've got cord below the tumor, you can use a D-wave electrode. And that's quite a robust wave to get. Because as I said, if that is preserved, even when you've lost motorboat potentials, the chances are you're going to have a transient deficit, but not a permanent deficit. And that deficit will improve over time. What else? Direct stim, sometimes we use, not very often. Some people describe neurophysiological techniques to try to find the midline and looking for something called phase reversal. I find that in my practice really, really difficult. There are some people who can do that. I can't. And that's largely what we use. As I said, when it goes up higher, so it's in the bulb, sometimes we'll monitor the lower cranial nerves, we'll monitor axillary as well. At least 11th, we'll monitor 12, 10, and 9, using those little hook wires that I showed you.
How can we overcome the delay in detecting the neurophysiology change while we are resecting tissue?
Sorry, say again?
The delay in neurophysiology.
Yeah.
During we face it in a couple of cases. There's a delay in neurophysiology detecting, oops, we have a problem.
Yeah. So when you run into problems with the neurophysiology, you need to first make sure it's not a technical thing. Secondly, you need to, so that's troubleshooting, and any good neurophysiologist should be good at that. You need to make sure it's no change in anesthesia. So one of the other things that I didn't mention was that we do all these patients under total intravenous anesthesia, because gas, especially in children, tends to interfere with the robustness, especially of somatosensory potentials. So we do it with total intravenous anesthesia. So if you're running into trouble, first check that there's been no change that your anesthetist has made. If those changes are real, and this is also why you have controls. So if you know the controls are normal, and the muscle groups of interest or the somatosensory potentials of interest have dropped off, the only reason is an anatomical reason, so something that you've done, then it takes one of 2 forms. Either it's a change in latency or it's a change in amplitude. So either it takes longer for the signal to get through, just very basically, or the amplitude of the signal is smaller. So somatosensory potentials tend to drop off in that way. Motorboat potentials can be an all or nothing phenomenon. So sometimes you can see a decrement that's real, that's causing you some worry and some genuine worry, or the motorboat potentials can be there and they can be gone. That's always a very difficult situation, and that's where the D-wave electrode really helps. So it's latency and amplitude that we look at.
Okay, good. If anyone have any question, or should we conclude the session?
Yeah, one more question. Do you ever use intraoperative ultrasound after you do the laminectomy?
Yeah, absolutely. Sorry, I meant to mention that. So intraoperative ultrasound is a great tool. Generally quite inexpensive, probably very much underused. Great alternative to intraoperative MRI, which very few of us have. And the way that one would use it is in two ways. One is when you've done your laminotomy to ensure that you over the correct segment where you're going to open the dura. Sometimes in young children, you can even see it through the lamina, the tumor through the lamina, and most of the tumors are very echogenic, so they show up really, really well with ultrasound. And then you can also use it as a tool for trying to determine how much tumor is still left when you're doing the resection. So apologies for not mentioning that, but intraoperative ultrasound is a great tool.
Okay. I have a question here. What is the mechanism of these tumors causing scoliosis in this patient? And can we differentiate the scoliosis caused by a tumor versus more being orthopedic cases from a clinical examination?
Not in any way that I can determine. I've seen severe scoliosis, severe kyphoscoliosis. Obviously, if there is an existing congenital lesion, or there is associated with other systemic conditions, it makes a congenital lesion and therefore congenital orthopedic problem more common in the cases that don't have tethered cords, for instance. The tumors tend to be very slow. So it's a very slow and relatively mild scoliosis compared to the orthopedic cases that I've seen. These tumors in children have usually been there for a long time. The canal's widened, and it's always a neuromuscular problem. Do you know of any other way of distinguishing between the two?
I didn't know, to be honest.
Sometimes if the is an atypical curve, like usually the curve of the scoliosis, I think it's going away from the heart, like right-sided curve. If it goes towards the heart, like a left-sided curve, then you start looking for atypical things. Also, many times your orthopedic colleagues, before they do the scoliosis surgery, they want to look for tethering of the cord or syrinx or something like that by doing an MRI, and then sometimes a tumor picks up, and they would ask you actually to resect the tumor before you correct the scoliosis.
Oh yeah, absolutely. So for scoliosis that is atypical, of course they must all have an MRI scan, and you're going to pick up spinal cord tumors, syringomyelia, tethered cords, and the general principle is that always the underlying pathology always needs to be addressed before the scoliosis is addressed.
Okay, I think there is no further questions from the audience.
Great. Well, feel free to contact me or any of the other colleagues that I mentioned. For those of you, if I could just put in a punt for the ISBN, it's a really great organization. For those of you who are interested in pediatrics or have any kids in your practice, it's a wonderful organization to be part of. We meet annually in different parts of the world. This year we're meeting in Birmingham. So Girish Solanki is hosting the meeting a little bit later on in the year. You can go to ispneurosurgery.org and you can find out all the details. Thank you.
Thank
you. Thank you very much. And thanks for everyone who attended.
Thank you very much, Professor. Thank you, Dr. Amr, and thank you for all attendees. You can find our previous webinars on our channel on YouTube, including the great talk from Professor. Thank you very much, everyone. We conclude our session.
Great. Thank you. Bye then.
Thank you. Bye bye.